too fast, climb stairs, get excited, have chest pain, may have arm pain, sweating, drop in blood pressure, we're going to see them right away. And we're going to do some of the things I'll tell you about later to maybe help them if we can. The patient we'd really like to find is the person who's going to have a heart attack, the one who has no symptoms, the one who's narrowed the vessels just enough so they get along fine, and maybe even on exercise they do okay. That's the person we may find dead on the floor next to the exercise bike, or out on the road lying by the side of the road because they didn't know they had trouble. They were asymptomatic. That's the patient we would love to pick out because that's the patient we can help the most. If we can tell who that patient is, then we can do a lot to help them not get into that situation and do some of the repairs that have become so popular. How can we do that? This is one of the most beautiful parts where physiology and anatomy and clinical practice come together. First thing you can do is an ordinary treadmill exercise stress test. You put the patient on a treadmill, which is just an exercise machine. Patient is wired like an astronaut. Patient has EKG monitors strapped to the chest, blood pressure cuff, an IV going, and is placed in a room with a cardiologist and a technician, lots of emergency equipment, defibrillators, medications. And we start the patient walking at a leisurely rate. And then every so many minutes, on a very set and fixed schedule, we increase the rate of speed and we monitor heart rate and blood pressure, both of which should go up in a normal person. Then eventually you get to the point where the patient may not be able to walk or run any faster. We can actually start elevating the treadmill, and we get different levels from 1 through 7 that are clearly defined as to speed and elevation and so on. Some of these patients who have serious disease will immediately start telling you, I have chest pain, my arm's hurting, they sweat, their blood pressure may get out of order, either too high or too low, and the test is immediately stopped. That's a positive stress test. It may take later. It may take a much longer time till the patient tells you they're having trouble, or they may not develop symptoms, but they might develop EKG changes, which I'll tell you about in a few minutes, that tell us they're having a problem, that the heart is not getting enough blood during diastole. But it's got even more sophisticated than that. It's gotten to be where we can really pick out patients who may have negative stress tests. In other words, nothing shows up on the treadmill, but we can see something in their heart. What we do is something called a thallium stress test, which is actually now even being replaced by something more refined. Thallium is an isotope, a radioactive isotope, that selectively is taken up by the myocardial muscle. Here's what we do. We can see this isotope using a very sophisticated Geiger counter, and it can give us an image in color of where the blood flow is to the heart. We can see bright yellow and bright reds for good blood flow and pale blues. The computer is just told to label them that way so we can see them, where there's no blood flow. And we get the patient on the exercise platform, whatever way we're going to use it. And we do the stress part first. We don't inject any thallium. We have the patient get going and get up there until they tell you, now with no symptoms, I can only make it about another minute. They're puffing, they're sweating, they're really going, the heart rate's up around 160, they're not feeling pain, the EKG is fine, and the patient finally gasps, yeah, I can do this for a minute, but that's about it. Then you inject the thallium intravenously. It rapidly circulates throughout the body, and it ends up being taken in the myocardium everywhere there's blood flow. It won't be taken up where there's no blood flow. So it's going to find the good areas of the heart, and it's going to not be there in the bad areas. Patient then comes off the treadmill, and we let the patient rest, because the thallium will stay there for a very long time, many hours. This is why we have to do it backwards. The patient now rests for 4 hours, and we do another scan. At this point, the blood will now go back to the places that may have been constricted during exercise, and we can see what was normal, because we have to compare before and after. Here's what a thallium stress test will look like in somebody who's got a problem. This is a patient who had no symptoms and went on the treadmill and got his thallium injection. This is the rest picture. Now, what this is a horizontal slice through the heart taken by the Geiger counter, it is really only showing you the left ventricle. So if you can picture the cone shape of the left ventricle being sliced across, this is the ventricle itself where the blood is. This is the myocardium. It's very thick. We don't see the right side here. The reason we don't see the right side is it takes up so much less thallium that we just don't get a good picture in comparison because there's not that much muscle. Now, before exercise, it would look like this. In this case, of course, we've done it after the exercise when the patient's rested. But this is your resting thallium stress test showing good flow everywhere in the heart. The blue areas are the very edge of the heart, which doesn't have a big blood supply. That's really epicardium. There's endocardium. No thallium visible in the blood itself here because it's all in the heart at this point. Look what happened to this patient during stress. This patient has a whole area of his heart which is not showing any blood flow at all. This is during that very short diastole, but the patient had no symptoms. This is a positive stress test. This patient is a very good candidate now to have an arteriogram. We can take dye and run it through the heart and see exactly which vessel is involved, although the thallium stress test will tell us by what part of the heart it is. What vessel will confirm it by doing an angiogram, an arteriogram to the heart, in which, again, a catheter is threaded up through one of the vessels, again from the leg of the arm, and this time it's threaded up through an artery, and it goes back up through the aorta, and is pushed into the coronary vessels selectively, and dye is injected. We can see if there's inflow, we can see where it's blocked, and then if there's outflow from another vessel, we can sometimes bypass that block. That's a coronary bypass operation. And this is how we find the patients we can probably help the most. So that's the stress test, and that is a test that, while not perfect, any test we do is not necessarily perfect, gives a very good indication of the asymptomatic patient who might be very well helped by some kind of intervention before they get in trouble, before they knock off some heart muscle that may or may not kill them, and before they lose a lot of function. There's a lot of debate today whether this actually prolongs the total lifespan of the patient or whether it gives them a total life